Hello, today I'll be talking about inflammatory bowel diseases, and that's Crohn's disease and ulcerative colitis. I have no conflicts of interest. So there are more than 1.6 million people in the U.S. with inflammatory bowel disease or IBD. About half have ulcerative colitis and half have Crohn's disease. There is a middle part, which is indeterminate colitis, which eventually evolves to become either ulcerative colitis or Crohn's once the patient has had the disease for a while and it's worked up. So in terms of ulcerative colitis, about 28% of people have proctitis or just rectal inflammation. Almost half have pancolitis or total colon inflammation, and about a quarter have just left-sided disease, and that's inflammation to the splenic flexure. In terms of Crohn's disease, it can occur anywhere in the GI tract, all the way from the mouth to the anus. So we have some patients with just oral Crohn's disease or oral ulcerations, and a very few patients with perianal disease, with perianal fistula or abscesses. So Crohn's disease most commonly occurs at the end of the small intestine, and almost half of the patients have ileocolitis or inflammation of the ileum and colon, about a quarter just ileal inflammation, and about a third just colon inflammation. So there is an age-specific incidence of inflammatory bowel disease, and it's a young disease, such that most of my patients are actually younger than me. It occurs really at an age range of about 15 to 35 for both diseases you see in Crohn's. And then there's a second smaller peak in the older ages, about 60 to 80. The presenting symptoms of ulcerative colitis are bloody diarrhea, and it can happen over a fairly short period of time. And of course, you want to rule out an infection, which is the first thing. You can get a fecal calprotectin, which measures colon inflammation, as well as testing for bacterial infections and C. diff. Patients also present with abdominal cramps and tenesmus, which is urgency to use the bathroom again and again. If there's pancolitis, patients will experience weight loss and some low-grade fevers. And again, the symptoms really depend upon the extent and severity of inflammation. If someone just has rectal inflammation or proctitis, they will present with constipation and bleeding. Whereas if the disease is more extensive, patients will have pain over the area of inflammation and have more diarrhea and more systemic symptoms. And this is a colonoscopy of the different spectrums of ulcerative colitis. The first is normal. You can see normal mucosa, and then mild inflammation with mild erythema, moderate, and then severe. And this is a mucosal disease, so it affects just the lining of the colon. If you see punched out ulcers in the colon in a patient with ulcerative colitis, that's very worrisome. It means their colon is going to perforate and they're going to need surgery. So in terms of classifying UC severity, patients with mild UC have less than 4 bowel movements a day, plus or minus blood, normal sed rate, and no signs of toxicity. Moderate severity is more than 4 bowel movements a day with blood, with minimal signs of toxicity, such as fevers or pain or weight loss. Severe UC is more than 6 bloody bowel movements a day, fevers, tachycardia, anemia, high sed rate or CRP, and these patients are more worrisome. Fulminant is a patient who's really hospitalized on IV steroids or infliximab. He or she has more than 10 bowel movements a day with blood, continuous bleeding, and is toxic. And here you want to prevent the colon from perforating. The moderate to severe patients are the ones that will require biologic therapy. The presentation of Crohn's disease can often be slower, more insidious over a longer period of time. Patients will present with a chronic diarrhea, abdominal pain and tenderness over the area of inflammation. And again, the presentation really depends upon where the inflammation is. If someone has duodenal Crohn's disease, he or she will present with a gastric outlet obstruction. If a patient has small bowel Crohn's disease, they can present with a small bowel obstruction. Fistulas can extend from the rectum to the vagina or from the bowel to the skin. Patients can present with weight loss, sometimes severe, low-grade fevers, perianal disease, In fact, patients with colonic Crohn's disease, a third of the time have perianal disease, so you should check for perianal fissures, fistulas, and abscesses. And again, as I said, the symptoms really vary with the location of disease. So Crohn's disease starts out as an inflammatory process, inflammation of the bowel. Patients will have abdominal pain, tenderness, diarrhea, and weight loss, and then evolves, if there's no medication, to obstruction or fistulization. If a patient has bowel obstruction, he or she can get cramps, distension, vomiting, and will often need surgical intervention. A fistula is a connection from the bowel to adjacent organs. Crohn's occurs through all the layers of the bowel, so patients will get microperforations, which form fistulas. They'll cause diarrhea, pain. If there's a bowel bladder fistula, a patient can get air or feces in the urine. There are many different types of fistulas, small bowel to small bowel or colon to small bowel, enterovesical, bowel to bladder, retroperitoneal, or bowel to skin. Women can often get rectovaginal fistulas, not uncommonly, especially with colonic inflammation. So to understand the severity of Crohn's disease is a little bit complicated, but I've laid it out for you here. Patients who are in remission are asymptomatic, and it's either spontaneously or after medical or surgical intervention. 80 to 90% of Crohn's disease patients are really in remission at any given time. Mild to moderate disease, patients are ambulatory, able to tolerate a diet, there's no dehydration or toxicity or abdominal tenderness, and patients do not need to be hospitalized. For moderate to severe, and here's the group of patients that need biologics. So please pay attention to this group of patients, really. They have failed treatment for mild or moderate. So they failed a course of ASA agents or budesonide or antibiotics, and their symptoms are persistent. They have fever, weight loss, abdominal pain and tenderness, intermittent nausea or vomiting, or anemia. Severe fulminant disease, patients who have this are often hospitalized. They have persistent symptoms despite high-dose steroids or biologics as outpatients. They can develop complications of Crohn's, such as abscesses or fistulas, which are very hard to treat, or bowel obstruction, and often they will need to be hospitalized. So I wanted to show you some of the indications for biologic therapy. So it's difficult to know who to treat with medications like infliximab or vedolizumab or ustekinumab. And here are some criteria, both for Crohn's disease and ulcerative colitis. For Crohn's disease and ulcerative colitis, you want to treat early and treat aggressively with biologics. The patients with Crohn's disease who require biologics are those with a complex fistula, particularly perianal fistulizing disease, deep ulcerations on endoscopy, on colonoscopy, especially if they occupy more than 10% of the colon. Someone who's young, because patients at a young age tend to develop more severe Crohn's disease and ulcerative colitis. A patient who is dependent on steroids or even resistant to steroids. Someone who has high-risk anatomy, for example, jejunal stricturing, jejunal fistulas, or inflammatory disease. It's normally extensive small bowel disease, or extensive colonic and perianal disease, or severe disease activity, weight loss, low albumin, or anemia. The indications are similar for early treatment in ulcerative colitis. Again, moderate to severe UC, steroid-dependent or refractory. Refractory pouchitis. Now, pouchitis, ileal J pouch is a surgery that is done when someone has severe or fulminant ulcerative colitis. The colon is removed and the small intestine is looped into a pouch so the patient is continent. And that pouch can be inflamed. And sometimes we use biologics to treat this. And also, biologics are used for maintenance therapy to maintain moderate to severe disease and keep it in remission. This is a colonoscopy of a patient with early Crohn's colitis. And here you can see erythema, and this is the appendix. And it really contrasts to this picture of someone with severe Crohn's colitis. Crohn's goes through all the layers of the bowel. So you can get very deep ulcerations here. And this is someone with severe Crohn's colitis. And infliximab would be an appropriate medication to give in this scenario. This is an MRI of a patient with Crohn's disease. And here you can see a gastric transverse colon fistula. And you could also see inflammation of the terminal ileum here and right here of the small bowel. And this patient eventually had surgery, and he's doing quite well. This is a picture of perianal disease, a perianal abscess in a man with Crohn's disease. And this often needs to be surgically drained and the fistula delineated and drained, and then a medication like infliximab can be started. So what are the newer management concepts in 2020 for moderate to severe IBD? Treat early. Don't let it get to the point where there are many fistulas or a bowel obstruction where a patient will need surgery. Treat aggressively with top-down biologics. Start with biologics. Don't use that as your third or fourth choice. Check drug levels. You can check drug levels of most of these biologics to see where you're at and see if you need to decrease the interval of infusion or injection or give more. Use dual therapy, an immunomodulator such as Imuran or 6-mercaptopurine and a biologic, and aim for deep remission, not just clinical remission. Someone says they feel better, but do an endoscopy, biopsy, make sure the ulcers are gone. Do an MRI, make sure the fistula or inflammation is gone. So what are the data on the efficacy and safety of biologic agents? So infliximab was first approved in 1997 and is one of the main medications for Crohn's disease and ulcerative colitis. In 98, it was approved for Crohn's, ulcerative colitis 2005. And then we have adalimumab in 2007 for Crohn's, certolizumab for Crohn's, natalizumab, adalimumab for UC, golimumab, and vedolizumab for both diseases, and then ustekinumab for Crohn's, and then ulcerative colitis. So we have a lot of biologic therapies to choose from, and many more in the pipeline. These are what the anti-TNF therapies kind of look like on a molecular level. The first is infliximab, and you should know that this is 25% mouse protein and 75% human protein, so patients can develop a reaction to infliximab, although it is a very effective medication for both UC and Crohn's. Adalimumab is completely humanized. Certolizumab is pegylated, so it's hooked to a large polyethylene glycol molecule. And even though it's not really as effective as infliximab or adalimumab, it can be used in some pregnant women with mild to moderate disease because it is not actively transported across the placenta. Golimumab is very similar to adalimumab, and it's used for ulcerative colitis. So there are many trials with these medications and very few head-to-head trials of medications because pharma makes so much money off of these medications. But these are multiple trials in ulcerative colitis of the anti-TNF agents, infliximab, adalimumab, golimumab, and this is for ulcerative colitis. And you can see they're similar in terms of their remission rates. And this is at 8 weeks, so after induction, and remission. For severe ulcerative colitis in the hospital, we used to use intravenous cyclosporin, which was quite effective, but this required a continuous IV drip. And there are also side effects associated with cyclosporin, such as high cholesterol and seizures. So when infliximab came along, we started using that for patients with severe ulcerative colitis in the hospital, and it actually is more effective. So cyclosporin has really gone by the wayside now. We're really using infliximab for severe UC in patients who are hospitalized at higher doses, not just 5 milligrams per kilogram, but 10 milligrams per kilogram, and giving it quickly up front to treat severe to fulminant ulcerative colitis. And these are the same diagrams for Crohn's disease. Again, it's very difficult to do head-to-head trials, but you can see adalimumab versus infliximab versus certolizumab, and the rates are about the same, although I tend to use infliximab and adalimumab more for Crohn's disease. So what are the adverse events with anti-TNF agents? Well, as I alluded to before, with infliximab, patients can get immunogenicity or react to the mouse portion of the molecule. Patients can get injection site reactions with adalimumab and certolizumab and or infections, which is why we do vaccines prior to giving anti-TNF medications. We make sure a patient has gotten the flu vaccine and the Pneumovax vaccine 13 and 23. There is a small chance of lymphoma, but this is very rare if the patient is young, and the incidence is very low with anti-TNF agents, even though it's slightly more than normal. Patients can develop lupus-like symptoms, but this is rare. Psoriasis, anti-TNF-induced psoriasis is a little more common, but usually this is treated by a dermatologist with a topical steroid. You don't want to give anti-TNF medications to someone with the myelinating disorders because it can make it worse. So it's contraindicated in multiple sclerosis. The same goes for someone with congestive heart failure. In terms of malignancies, they're rare. But you do want to make sure prior to giving anti-TNF medications that you check for TB, hepatitis B, and if possible, vaccinate with Shingrix for herpes zoster. This is a head-to-head trial, and it was a big trial in the New England Journal of Medicine, and the only head-to-head trial that I have seen for two biologics against each other to treat moderate to severe ulcerative colitis. And this is vedolizumab or Entyvio, and it's a newer biologic that just treats inflammation in the bowel versus adalimumab, which had been had prior approval for ulcerative colitis. And you can see overall that vedolizumab was better, even in patients who had had prior anti-TNF therapy. So it was better in terms of remission and endoscopic improvement, but not corticosteroid-free clinical remission. It was about equivalent. So in a way, we do now prefer to give vedolizumab if the insurance company will approve it for moderate to severe ulcerative colitis. Vedolizumab is also used in Crohn's disease of the small and large bowel, and here are some of the clinical trials, and this is the data at week 52, and there's good evidence for significant clinical remission, clinical response, and steroid-free remission. So where do we position vedolizumab? Well, at first, we gave it to patients who were unresponsive or intolerant of anti-TNF therapy, but more and more we're starting to use it first line. The first medication that you give, the first biologic that you give for Crohn's disease or ulcerative colitis works the best. So you really want to pick and choose the first medicine you're going to give. Unfortunately, we don't have a genetic test to tell us which medicine will be the best. So it's really a discussion with the patient. And you also need insurance company approval in terms of which medication they're going to take first. But we often use vedolizumab first line because it just affects the bowel and it doesn't have so many side effects. We definitely use it first line in patients who've had organ transplants, who have immunodeficiencies, who are elderly because there's no risk of lymphoma or systemic infection with vedolizumab. We use it in cancer patients as well because anti-TNF therapy is linked to melanoma and non-squamous and squamous cell skin cancers. You, however, can't use it in patients who have extraintestinal manifestations such as arthritis or uveitis because it just affects the bowel. Ustekinumab is also an effective medication for ulcerative colitis, and this was just approved. And here's the trial from the New England Journal of Medicine, and it was effective versus placebo in terms of clinical remission, endoscopic improvement, and clinical response. So this is another biologic therapy that we now have for ulcerative colitis. It's also used for Crohn's disease. It's one infusion and then an injection every 8 weeks. So where should we position ustekinumab? We can use it first line in Crohn's disease. Again, it's hard to know which medication to use first. Ustekinumab is an IL-12/23, vedolizumab is an anti-integrin, and then you have the 3 anti-TNF medications. So it's really hard to know what to use first. So we really kind of discuss it with our patients, and sometimes, all too often, it's actually dictated by insurance companies. It is good to use in a patient that has psoriasis because it is an effective psoriasis drug as well. So So this is really the safety pyramid for IBD medications. Steroids are the least safe, then combination therapy with anti-TNF and thiopurines, then thiopurines, then anti-TNF monotherapy, then ustekinumab, then vedolizumab. So this is the way I kind of look at it. Really, all of these medications are very safe. Thiopurines are in the middle because they are linked to lymphoma and some skin cancers, especially when patients are older than 65. But for all moderate to severe IBD, we really do choose one of the three biologics, and sometimes in combination with a thiopurine if the disease is really severe. There's now a new revolution in IBD therapy with small molecules, such as tofacitinib, which I'm sure you've heard of. These small molecules are low molecular weight. You can take them orally. They resist gastric degradation. They rapidly enter the systemic circulation. They have a short half-life. They lack immunogenicity, such as infliximab, and they're easier to manufacture. And tofacitinib is now used in ulcerative colitis. It's a rheumatoid arthritis drug, but it's now used in ulcerative colitis. And this was a big trial 3 years ago for the New England Journal of Medicine. And this is the response and remission at week 8. And the numbers are similar after a year. So this is a very common medicine that we use now. And again, it's a pill. We start at 10 milligrams twice a day and go to 5 milligrams twice a day. Some of the side effects of this drug are herpes zoster. It can reactivate shingles, so you want to make sure that your patient has a shingles vaccine. There were also reports of blood clots and pulmonary emboli in patients with rheumatoid arthritis who took this as well. So you want to make sure that your patient doesn't have a history of blood clots. But this is very helpful, especially during this time when patients don't want to come to the hospital or the infusion center. You can write this for them at home, and they just need follow-up labs. It can increase lipid levels, so we do follow patients' lipids as well. And again, many more of these JAK inhibitors are coming out. So in the next 6 to 12 months, I think we'll have a lot more medications that are a lot more specific, that really aim for very specific biological targets that will work in ulcerative colitis and hopefully also Crohn's disease. So what is non-response? What do you do if the medicine you've given doesn't work? Well, primary non-response is when a patient does not respond to a loading dose of the biologic. Is this patient a non-responder to all drugs targeting the same pathway? So if she doesn't respond to infliximab, will she respond to adalimumab? Probably not. However, I've found that patients who don't respond to adalimumab or certolizumab may respond to infliximab. Secondary non-response, if a patient did respond to a biologic but then loses that response or becomes intolerant or develops antibodies, then you can switch to another biologic in class. So if a patient develops antibodies to infliximab, you can then put her on adalimumab. Here's a diagram that may be helpful. So if you have secondary loss of response, you can actually check the blood levels of these drugs. And if they're therapeutic, you need to change to a different class, such as Entyvio, such as vedolizumab or ustekinumab. If there's a subtherapeutic level, if it's too low and the patient does not have antibodies, increase the dose. If the patient does have antibodies and there's very low levels, you can escalate the dose or add an immunomodulator. If the levels are high, you need to change to a different anti-TNF. So in terms of positioning of biologics in UC and Crohn's, the earlier the better in the patients that need them, and with possibly short-term combination therapy with thiopurines. And therapeutic drug monitoring is very helpful because often you have to increase the dose or decrease the interval. So I do want to talk about some extraintestinal manifestations of IBD, and there are many. Eye inflammation such as uveitis or episcleritis, lower bone density, you want to check your patient's vitamin D, liver and bile duct inflammation, gallstones, skin lesions such as psoriasis and skin cancers, kidney stones. Infertility is increased, especially patients who've had surgery. Low anti-Müllerian hormone, people can have early ovarian failure, arthritis and joint pain, and growth failure in children. This is a picture of a skin lesion, pyoderma gangrenosum. It's an ulcerating skin lesion. They can be seen in association with UC or Crohn's disease and often requires IV steroids or anti-TNF medications. This is a picture of erythema nodosum. These are hot, red, tender nodules, usually on the extremities, and they do respond to steroids, and they do correlate with an inflamed colon. These are bile duct lesions. The first is sclerosing cholangitis, which is beating and stricturing and inflammation of the large bile ducts mostly, although there is small duct sclerosing cholangitis as well. And this can lead to, in a small percentage, 10% or less, bile duct cancer. So this is something you really need to watch. And they always have a liver doctor follow these patients. There are different forms of arthritis that can be seen with IBD, peripheral, which does go along with the IBD flares, sacroiliitis, which also goes along with flares, and ankylosing spondylitis, which doesn't necessarily correlate with a flare of Crohn's or colitis. And this is a progressive fusing of the spine. And to treat this, infliximab is very helpful, and there are other medications that are being developed. But these patients are usually seeing a rheumatologist to help. Eye complications include episcleritis and uveitis usually requires oral steroids. So patients with IBD do have decreased bone density. So if you have an IBD patient who's used steroids for more than 3 months, either all at once or in their lifetime, someone who's had a fracture with low trauma, postmenopausal women, or men more than 50 or hypogonadism, just get a bone density. It takes about 10 minutes and is very easy. If the score is good, just basic prevention, which is something you want to recommend to patients, just calcium, vitamin D, exercise, stop smoking, avoid alcohol, try to minimize corticosteroids, and it helps to give budesonide instead of prednisone if we're able. Treat the hypogonadism. With osteopenia, you want to repeat the DEXA. You want to really consider a bisphosphonate. So I refer to a bone density doctor for this. If the score is low, I always refer to a specialist, and I really try and avoid steroids, and I also repeat the bone density. So there is an increased risk of colon cancer based on the extent of ulcerative colitis and Crohn's colitis. So if patients have had inflammation of the colon, that's more than a third of the colon, we start screening at 7 to 8 years after diagnosis. So we do colonoscopy and biopsy, and you can see these are the rates of colon cancer. They're slightly increased in terms of the extent. So if someone has left-sided colitis, is a higher relative risk than if they have just proctitis. Pancolitis is a higher relative risk. And what we do is we do a colonoscopy and 4-quadrant biopsies, or we can use dye sprays such as methylene blue, indigo carmine, and try and highlight dysplasia or precancer, and then biopsy it or remove any polypoid lesions. And this is done every 1 to 2 years. So what are the risk factors for colon cancer? There's strictures that cannot be passed. A patient, like I said, with extensive colitis, someone with long duration of disease. And after 20 years of disease, we actually screen more frequently every year. Someone with active disease, someone with active inflammation on and off is more likely to develop dysplasia and cancer. If a patient has primary sclerosing cholangitis, they're even at higher risk, and they actually need a colonoscopy every year. If there's a family history of colon cancer, they're at higher risk as well. So the take-home messages are: treat early, treat aggressively for moderate to severe IBD, use dual therapy with thiopurines and biologics, use drug levels to guide therapy, treat to endoscopic and histologic remission or deep remission, and the risk of a serious side effect is much less than the risk of a complication from the IBD itself. I now want to review several cases. So the first is a 22-year-old man who was recently diagnosed with Crohn's disease, who presents to my clinic to discuss treatment options. He is a non-smoker and does not drink alcohol. He only takes Lialda, which is a 5-ASA medication, a very mild medication, which is pretty inappropriate for him. A recent endoscopy shows superficial ulcers limited to the TI. He describes rare intermittent abdominal pain and 2 to 3 bowel movements daily. Recent labs suggest a normal CRP, a normal serum albumin. So which of the features of his disease puts him at high risk? Young age, non-smoking, superficial ulcers, terminal ileal disease, or the markers with like the CRP and the albumin. So I would say this gentleman is young, so he's more likely to have severe disease. Lialda is not really an effective therapy for Crohn's, so you might want to talk to him about other types of therapy, either budesonide on and off when he needs it, or if his disease becomes worse, then biologic therapy. So which of the therapies for IBD has the highest risk for immunogenicity or drug antibody development? Vedolizumab, ustekinumab, infliximab, adalimumab, or golimumab? Well, I said that infliximab had 25% mouse protein and none of the others do. So the most immunogenicity is really with infliximab. You can negate that by doing regular infusions and often by adding a thiopurine. But sometimes patients will develop antibodies anyway, and you'll need to switch to a different medication. The last question is regarding a 38-year-old man with a medical history of Crohn's, currently on infliximab at 5 milligrams per kilogram every 8 weeks. He presents with worsening abdominal pain, frequent bowel movements up to 15 a day, so he's pretty ill. He wants to discuss next options. You check a CRP, which is high. The infliximab level is good, though, actually. It's the level done right before the infusion is 12, and you're looking for a therapeutic level more than 5, and there's no antibody, so he's on a good dose of infliximab. So what do? Start azathioprine, increase the dose, discontinue infliximab, and start the biosimilar Inflexa. Now, I didn't have a chance to discuss biosimilars, but they're being used more and more these days. They're exactly the same drug, but just basically made by a different company and cheaper, and they can be used interchangeably with the originator drug. And when you check a level on the biosimilar, you can just check a level of infliximab, say it'll be the exact same thing. So it'll do the same thing as infliximab. Or you discontinue infliximab and start ustekinumab, which is a drug out of class, or you decrease the interval of the infliximab infusions to every 4 weeks. So in this situation, the level is therapeutic. It just isn't working. Switching to a drug in class like Humira or adalimumab or certolizumab, just isn't going to work. So you need to move out of class to ustekinumab. Thank you.